Wonderful. Welcome everybody to the InTouch Health webinar series. This is Larissa from Corporate and I will be your host for today's webinar. Today we will be featuring Dr. Christian Caicedo from Pinnacle Health, and he will be presenting on his telehealth experience. Dr. Caicedo is currently the Vice President of Operations and Medical Director for West Shore Hospital. Additionally, Dr. Caicedo is an Associate Chief Medical Officer for Pinnacle Health System and the Medical Director for Susquehanna EMS. Dr. Caicedo received his BA from Rutgers University, his MBA from Alvernia University, and his MD from New York Medical College. He is a member of Delta Mu Delta, International Honor Society in Business Administration, and Alpha Epsilon Lambda, Graduate Business School Honor Society. Dr. Caicedo is a contributing author for In a Page, Signs and Symptoms, a quick reference book on some of the most common medical complaints. Dr. Caicedo is also an avid Twitter user and has over 600 followers, more than any other physician at Pinnacle Health. We will begin our webinar shortly, but first, a few notices. You all should have been auto-muted. If not, please make sure you mute yourself. During this webinar, you'll be able to enter questions in the questions module located on your GoToWebinar panel. All questions will be addressed at the conclusion of the presentation, but feel free to ask your questions at any point during this webinar. The webinar will be recorded and a copy of the recording will be available on our website. A link will be posted at the end of this webinar. And again, this webinar presentation should last about 60 minutes, including the time for the Q&A. And now, without further ado, here is Dr. Caicedo.
All right. Well, thank you, Larissa. I appreciate the time and the opportunity to present. Let me just bring up my slides here very quickly. Thanks. As Larissa said, I'm the VP of Operations and Medical Director for West Shore Hospital at Pinnacle Health System. I have been with this organization since 2000 when I moved here from New York. And it's been a wonderful growing experience, not only professionally. I'm still a practicing emergency room physician, but mainly do administrative duties as the VP of Operations. But it's been wonderful as Pinnacle is a organization that has been very innovative and very supportive in the use of technology on many fronts of how we deliver healthcare. Pinnacle Health is in South Central Pennsylvania. It is a $950 million not-for-profit organization, 4 campuses, and 3 acute care hospitals. Our main campus is in downtown Harrisburg, which is the capital of Pennsylvania, 382-bed hospital, multi-specialty, anything from NICU and L&D to our palliative care services, as well as open heart program, and like I said, labor and delivery. Our other campuses, Community General Hospital is 145 beds, no pediatrics or labor and delivery, but a very comprehensive bariatric and orthopedic program there. And then my site is West Shore Hospital that was just finished and constructed back in May 19th of 2014, so just a mere 18 months ago. That is 108-bed, private rooms, high-tech, high-touch, really created a culture around the technology that we utilize here, as well as a very patient-centric and very focused on the experience and the quality of care that we provide here. A very large medical group, 1,000 providers, primary care and multi-specialty, and many other additional services that we provide throughout the South Central Pennsylvania region. Again, I sound enthusiastic because I'm very proud to be part of this organization and all the things that we've been able to achieve, especially with telehealth and technology. So I'm going to go a little bit through the story and the birth of telemedicine at Pinnacle Health. I'm going to highlight some of the things that we did with our approach, the support that we have gotten from senior administration and the system itself, and what some of the key factors are and kind of the secret sauce to making sure that you have a successful program. The growth that we have had thus far, and I can tell you, we started talking about telehealth at Pinnacle back in 2009. We vetted many vendors and processes over a 3-year period and then launched with InTouch in 2012. So it was not an easy process. We are 3 years old, so relatively in its infancy in comparison to some of the other programs that are out there. However, we've been able to really expand outside of some very traditional telehealth service lines and done some pretty innovative things that I'll highlight. And some of those things are outside the walls of the hospital. I'll also share with you some of the results that we have had and some of the things that we are contemplating at this time and how we're going to move forward with this program, given that consumerism in healthcare has really driven how we leverage some of this technology and how we bring forward to our patients some of the care that they're wanting in a very convenient and easy manner. So, telehealth solutions, obviously, as opposed to seeking care in an online provider or the use of a very high-cost arena like an emergency room, clinically appropriate and cost-effective steps can be taken by utilizing and leveraging this type of technology. Not only that, but as we move into value-based purchasing and full risks and capitated care, we need to start improving the flow and patient care and thinking about the cost avoidance that we need to put in place, since that value curve is going to kind of be switched, if you would. Right now we're in a fee-for-service world where we can do many things in order to achieve a certain level of revenue, but in the future we're going to have that revenue up front, and what we need to do is minimize the cost per case and the cost per care so that we can maintain that revenue and utilize it for further investments down the line. So our approach, we want to reduce costs, we want to improve integration of care, the quality, as well as patient safety. This is, all kind of 4 points that really touch on the triple aim, but I call it the triple aim plus because I think integration of this care is very important as we get bigger and bigger and amass this population that we're trying to manage with less resources and less intellectual resources, right? Because as we move forward, we're going to have a shortage of physicians in 2020 that are going to force us to further leverage technology in order to deliver care in that cost-effective, high-quality, very efficient way. One of the things that you need to consider when you're developing a telehealth program is that you have a very supportive administration. This is not a service line in itself. It is not something that one part of a hospital system can do alone. This should really be part of the vision. It should be a system investment in how you're going to leverage this technology across multiple service lines and across multiple sites. So having that support is going to be key to the delivery, making sure that you are annotating the value that is bringing. Sometimes that value is not economic, but in cost avoidance, which is a very interesting conversation to have with your CFO. And I'll explain a little bit more about that as I get into more of the non-traditional areas where we're using telemedicine. Supportive physicians and supportive staff, key ingredients to success. If you don't have a physician that's going to help you drive telehealth in a specific service line, that program is not going to go anywhere. Right now, we still have a program, like I said, that's in its infancy, and telehealth itself is in its infancy, and physicians are very skeptical and sometimes utilizing this technology because they're very used to the traditional way of delivering care. So you need to have someone who's going to be able to champion not only the process and the use, but innovate of how they're going to use this technology, because there are ways of utilizing telehealth technology that we haven't even thought about yet. And the physicians that are actually on the ground doing it are going to help you innovate that way. And supportive staff. I'm going to speak to you a little bit more about that because when I speak about the TeleSNF program, because some of the folks that will push back very strongly are going to be your nursing staff and ancillary staff of how you're going to utilize this technology. There is a wonderful book called by Jeff Colvin called Humans Are Underrated. And we have transitioned from a very knowledge-based skill set to a relationship skill set culture. We need to ensure that we have people in place in our jobs in healthcare moving forward that can understand how they're going to leverage the technology, the clinical decision tools that are going to help us with our left brain activities, and we can focus on our relationship skills, because then we'll deliver a better product that way. It's a really interesting book because the use of telehealth can really be aligned with the Industrial Revolution. People thought that they were going to be replaced by this, but in turn what we need to look at is the opportunities of new ways of doing our jobs so that we can deliver better care. I just say that because, again, these are some of the ingredients that are going to make you successful. So the team. So we have a team, a physician champion, a clinical coordinator, and IT specialist that are part of my group. Fortunately, I had some folks that were very invested and very interested in telehealth technology and were able to help me grow the program. Some of those folks have moved on to other positions at Pinnacle, and I'm very happy for them because they're really growing. I continue to be the overall physician champion for telehealth here at Pinnacle, and I have a clinical coordinator who's a nurse that helps me operationalize some of the initiatives that we have in place. I have lots of great support from our IT specialists, but the reason I bring this up is because even though we have this overall team that kind of oversees this product, if you would, you need to have physician champions, clinical coordinators, and IT specialists within the service line where you're going to deploy it so that they own the process. As much as I would love to be in neurology and ID and wound care and toxicology and all those places helping support the program, but what we really need is someone within that service line that's going to own the process and just make this part of their cadence and part of their armamentarium to deliver care. So we have identified those folks so that they can move it forward, and we just help support them make it a successful deployment. So when we started back in 2012, this was our approach. We just need to help ourselves. We started with a non-traditional model. This was not a hub and spoke model. This was really our neurologist, which is a finite resource that we needed to leverage amongst or across multiple sites. What we needed to do was put this tool in place so that when we had a stroke and we deployed or initiated a stroke alert, those neurologists can beam into our RP lights in the emergency department and help the emergency room physicians, myself included, to make a decision whether TPA was going to be initiated or not. We had a lot of great success. We were able to decrease some of our times from door to needle by 22 minutes. We received a Highmark Silver Award because of that. This was a great satisfaction also for our neurologists, and it was also, what was very interesting was also a very key recruiting tool. Some of the new neurologists that were coming out of residency had already had some experience with telestroke technology and were very interested in knowing if we had that capability, so that was very useful. What it also led to was the interest in other areas throughout the institution that really became interested in how this technology was going to be utilized in their area. We were able to expand into our wound care services, infectious disease, as well as toxicology. And then I'll speak again about our TeleSNF program. But it was also very interesting because what this led to was partnerships with some of our more rural sites that we have either a management agreement with or a strong partnership with, that we were able to deploy some of this technology to help them get some of these subspecialties that they would not have had access to otherwise. Also very well received. It's been something that's been very successful. And for those of you that are not in Pennsylvania, you know, we have the challenges that CMS has put in place that unless you are outside. That means the patient is outside of a metropolitan statistical area. We're not able to bill for those services. So, these rural sites that we have partnerships with, we were able to, put these things in place and be able to bill for those encounters, which was quite the learning experience, by the way. You need GT modifiers. You need to document in a certain way. Our providers needed to understand how they needed to document in order to appropriately bill for these. But again, it can be done, and you just need to have some expertise in the billing world in your area so that you can get that deployed correctly. Some of the financials results that we were able to see with our TeleSNF program just initially, because we have a very robust post-acute care network, were, as you see in this slide, we were able to decrease in one of our TeleSNF facilities our readmission rate by 14%, which accounted for about $250,000 to $280,000 in savings. Those are penalties that we were able to calculate that we would be penalized with here at our site, our system, should these folks would have come back to the emergency department or be readmitted into our hospital. That's not including transportation costs or actually ED visit costs. Like I was saying before, only 2 of the outside hospitals outside of the metropolitan statistical area, the ones that we're able to bill for. But again, that has been a very good program that is growing with other service lines. And we have not had any issues with patient satisfaction. Actually, part of the secret sauce of deploying a good telehealth program is having your marketing folks be involved in this. You need to ensure that you have good communication with not only the providers and staff at the facility you're going to deploy it in, but with the patients and their families so that they understand what this technology is there to do. We've actually had some experiences of folks that just want to see the technology and want to see the robot come and have someone beam in so they could experience it even though they're not actually having a subspecialty consultation. So one of the other three things that I wanted to mention beyond neurology and beyond the TeleSNF was the toxicology, wound care, and emergency management. Again, finite resources. Toxicologists are tough to come by, and if you're calling poison control, that is a good way of utilizing a resource that's going to help you manage some folks that can come in with some toxicologic event. However, having someone that can beam in and actually see what that patient looks like can help you differentiate where you're having a serotonergic event or if this is some sort of benzodelirium or whatever the case may be, and help you really manage that those folks on the ground. Wound care was also very successful, not only with a physician wound specialist seeing patients and doing consultations at our remote sites, but we were also able to leverage the technology so that our wound nurses within PinnacleHealth here in our hospitals did not have to drive from site to site so that they could see all the wound consultations that they were receiving throughout the day. This has been very successful because it's been a good satisfier for them and the family, so you can have timely evaluations by those people with those expertise, as well as maximizing their talents and decreasing length of stay and improving our discharge time of day. Emergency management I bring in because it's one of the pilots that we did. There's a picture there on the right where we're on the at the command center where we did a regional exercise with multiple hospitals. We actually had an RP Express that was in one of our EMS buses that was on the side of this supposed mass casualty event, so we could see what kind of patients were being sent to our sites or others, and then when the RP lights in each one of our EDs so that we could see the volume, the walk-in volume, and the EMS volume that's being brought to our facilities. I think it was very well worth the pilot. I think it can be leveraged in multiple areas, and when you have mass casualty events, this could be a great tool to help you manage patients that are coming to your facilities. So, Colonial Park Care Center. We have a post-acute care network that is made up of 7 facilities. We have multiple facilities in our region that now want to be part of this post-acute care network because, as you all know, the partnerships that you have with the extended care facilities can help you manage the costs, especially for your ACO patients. We have a Medicare Share Savings Program, ACO, that we are managing around 48,000 lives in this region, along with our primary care folks, some partners in Williamsport, which is north of us. So those individuals we are, closely following just how well their outcomes are and how much we're spending per beneficiary. So, managing the cost in our extended care facility and those partners is very important. Colonial Park Care Center is literally a stone's throw away from Community General Osteopathic Hospital, which is the second site that I showed you on an earlier slide. And they started out, like I said before, about 22%, 23% readmission rate to our facility. A good facility. They needed some support with some education and tools. And we started with the post-acute care network. Let's look at the data. What kind of readmissions are coming back? What kind of resources do you need on the ground in order to keep your patients there? And, improve the quality that you're providing. So we started out with the Interact tool and the SBAR tool. We actually have one of our nurse clinical coordinators and our director, executive director for case management, went out and visited with these folks so that we can implement some of those tools for their staff. In addition, we put in an RP Lite on their site so that their providers can actually utilize it to see their patients. Dr. Sahi, who's the medical director at that site, is actually one very innovative and very engaged individual. He utilized that robot. So the staff was trained in Interact and SBAR. Then he utilized that robot in order to beam in and evaluate patients that he was getting a phone call about because of some sort of acute change. The difference was that he was there on the ground on a regular basis evaluating those patients. He knew exactly who was high risk, who had the highest risk for readmission or a visit to the ED. So what he was doing in the evenings was he was proactively rounding. So he would tell his nursing staff, if there's an issue, please call me, I'll beam in. Or at 7 p.m., what I'll do is I'll beam in and we'll round again on those folks that evening that are high risk and see if we need to change anything in the care plan. That led in one quarter to a decrease of about 5% in the readmission rate just to that one hospital, which equated to about $50,000 in savings in that. So that generated interest, obviously, in the other facilities. And now we have additional providers that are utilizing it at that specific site. I'll tell you a little bit about the other ones. So the other 6 sites, Golden Living, Jewish Home, Spring Creek, Messiah, and ViberLife have all expressed interest, obviously, in this technology and things that we were doing with Colonial Park Care Center. This past summer, we deployed the past 6. The last one was deployed. Actually, it's being delivered in the next 2 weeks, and we're going to do some training, and we continue to do training at the other side so that we can start the measurement this second quarter into the third and see if there's going to be any impact on readmission and ED visits from those sites. Very well received, very excited. The physicians, like I said, some folks were very skeptical about how this could work. But seeing the results from Colonial Park has really led to some adoption and excitement about how to utilize this tool. So the reason I bring up lots of these numbers and lots of the readmission conversation is because, like I said, pay for performance, healthcare reform, we're going to have these penalties that started at 2%, and I'm going to show you a chart of what those look like as the years go by. In fiscal year 13 for AMI, heart failure, pneumonia, now COPD and joints. and as well as in 15 for unplanned readmissions. Readmissions are a marker of substandard quality care and compromises in patient safety. These are all things that can lead to impacts on your reputation, whether you're the SNF or the hospital system, that needs to be taken into account. So this is the chart that I wanted to point out. As you can see, in 2013, 1% of the Medicare reimbursement can be penalized, and as we move forward into 16 and 17, 3% of the Medicare reimbursement can be penalized. Those are significant numbers when you talk about a system like ours, not to mention that in 2018, October of 2018, now there's going to be penalties to this extended care facility should they have a certain number of readmissions going back to some of the hospital systems, starting at 2%. Now, the ability or the opportunity is going to be that 70% of those dollars that are being collected will be redistributed to high-performing providers that reduce hospital readmissions. So there is an incentive to perform very well and minimize that readmission and hold on to your patients. So, there's an opportunity both ways. You hold on to your patients, you're billing for them, you're not getting penalized, and you have the opportunity to capture and share in that 70% of those dollars that are being collected from other underperforming. So those are really important numbers to keep in mind. And as you move forward, it should be part of the conversation that if you're about to deploy a telehealth program, especially to the SNFs, that is an important conversation or point to make when you're talking to your CFO. So one of the things that is part of the conversation is, are you doing, or am I doing something that's going to be, am I ahead of the curve, in other words? So, for those folks that don't fall under those DRGs or those diagnoses that we would get penalized with, if somebody gets actually readmitted to the hospital, returns to the hospital, in the current model, we can bill for it. We're actually making revenue off of that patient that comes back to the hospital. However, if we are not deploying this type of technology and this type of program and getting ready for what's going to come in the next 12 to 18 months, we won't have the infrastructure in place when we switch to that capitated or full risk environment. We won't be ready to manage that population in the appropriate manner. So, you have to be careful that you're not too good and you're leaving money at the table, if you would, in the current model, but you need to ensure that you're preparing for what's going to come in the next 18 months so you're prepared to manage that risk. These were the things that we were able to calculate for the hospital. Here at Pinnacle, the readmission penalty was costing us around $8,000. That's not including the hospital transfer, EMS transfer itself, or the ED visit. And nursing home, the penalty that we were calculating according to what their Medicare reimbursement on average for a post-acute care was around $4,000 in penalties per readmission. So I just throw that out there because these are numbers that need to be calculated in your particular markets so that you know exactly the numbers and dollars that you would be working with. So what's next? Expansion of the specialty use. We're actually looking at how do we bring specialists into our nursing home facilities, or how do we deploy some of this technology with some of our patients home with them. There are other facilities that are already sending RP Express home with them so that they can be evaluated either post-surgically or post-admission. And that's been working very well as far as making sure those high-risk patients do not return, or that we are managing medications or any other issues that could come up after a discharge. Additional deployment into the additional nursing homes, like I said, that's 6, and expansion into management and educational activities. There is a tiered approach that we take with telehealth. We want to make sure that we are using the right tool for the right environment or right venue. We want to make sure that we're maximizing the utilization of the high-cost tools to maximize the quality of care that we're providing to patients. So there is a tiered approach to that. One of the things that I wanted to mention is one of the calculations and projections that we have is once we have deployed and everything is up and running, just like Colonial Park Care Center in the additional 6 post-acute care SNFs partners, we're looking at a savings projection of about $1.6 million a year. That is a significant number that will allow us to further invest in other technologies and other things that will improve quality care and improve the outcomes of the folks that we're caring for here at Pinnacle. Expansion into other specialties, like I said, we are looking at work clinics, some correctional facilities, affiliated facilities. So one of the things that has been very interesting in conversation is that, it's not always a large health system that can provide services to smaller ones. One of our partners has an inpatient psychiatric unit, and they're out in a very rural area, actually, and they have 2 to 3 psychiatrists that have capacity to help us manage some of the patients that we have here. Here at Pinnacle and in Harrisburg, we have a shortage of psychiatrists, so we're actually looking at a model where they can provide psychiatric services back to us, which is an interesting thing because, they're the smaller site, but they have the resources that they can leverage for us, especially in our emergency department. We have a huge issue, just like everywhere else in the country, where we have an average of 13 psychiatric visits in our main hospital a day, which can lead to, utilization of clinical beds rather than our psychiatric pod to see those patients, which can lead to other bad outcomes or left without being treated and things that impact the overall operations of the ED. We have already deployed rheumatology and endocrinology at our spoke sites. Our rheumatologist is doing virtual visits outpatient at our remote sites a couple of times, once a week, every other week, and he's on there for 7 hours. So he is seeing patients on a routine basis at these sites. And endocrinology just started about a month or so ago, also once a week, and that's looking to grow, especially at the remote sites. Management and education, multiple sites. I utilize other audiovisual type of services so that I can beam into meetings and I don't have to drive back and forth amongst all of our campuses. Clinical education, we're also using it so that our residents don't have to go from site to site, and we can leverage the expertise. Tumor, M&M can be done at one site, and we can watch it here, as well as some of the other clinical education pieces. One of the things that I'm excited about is our community health navigation network. We are utilizing soft endpoints, so Surface Pro right now, where our nurse manager from the hospital actually goes out and sees high-risk patients that are high utilizers of our emergency department and or have certain morbidities that put them at a higher risk for readmission to the hospital or ED visits. They go out and they visit these individuals. They use the Surface Pro, and 2 of our internal medicine physicians will beam in and evaluate that individual along with that nurse. The initial pilot that we did, they saw in a period of 3 weeks around 7 patients. I can tell you that in the past 2 weeks, they have seen 10 patients. We have also rolled that out to our community paramedicine program, which has also led to additional patients that they see, mostly congestive heart failure patients, that they do vitals wait and med reconciliation within 7 days after being discharged, so that can reevaluate those folks and make sure that they're taking their meds correctly, that they understand their care plan, and if there's anything that needs to be changed so that it decreases the readmission rate or visits to the ED. Again, those two physicians from our medicine group are the ones that beam in and help support these individuals. This is a slide with just those initial 7 episodes where the types of things that they were seeing with those high-risk patients. I don't have an example of the paramedicine one, but again, CHF is something that it's big. It's one of the cohorts that they follow very closely. This is just 3 of the insurance carriers of those individuals that were seen on the previous slide, and where the savings per pair are. If you look at an ED average cost, ED average reimbursement, a visit to the office, or having this done, and what kind of savings you're seeing. As you can see, Gateways are Medicaid managed company that manages that cohort, and that has paid dividends, if you would. If you look at this, and if we were to scale this up amongst multiple case managers, which we are ready to deploy, I think we would see some significant numbers in savings there. Okay, so I have given you a lot of information. I hope that it gives you a sense of what we have been doing. There are lots of opportunities of leveraging telehealth to provide better care, to generate some cost savings, to drive interest in your community, in your health system. There are multiple things that are on the horizon and that have already been deployed that will help expand the use of telehealth in the community. Direct-to-consumer solutions are something that are growing, and I think it'll be something that you'll see more and more, and health systems become part of it. Just like social media, if you're not part of that conversation, if you're not answering those questions or getting out there, you're going to be left behind. I think telehealth is one of those things as well in healthcare that we just need to be part of it, invest in it, use it to the best of our ability. That's going to add the greatest value to your patient population. So I hope that that's helpful.
Dr. Caicedo, thank you so much for a very comprehensive presentation. We do have a few questions from the audience, so we'd like to jump into those. One of the questions comes from Elizabeth, and she asks about who takes care of the cost for the skilled nursing facilities.
Great question. So when we did our pilot, Pinnacle invested on the total cost of putting that robot in for that first year. Now, as part of our post-acute care network, we share in the costs 50-50 of the lease of that robot on a monthly basis. So it's a shared cost.
Okay, great. A couple more questions. This one is from Olivier. It comes in and asks, was there a key moment when you knew that telehealth was more than just a telestroke program?
Another great question. So as the clinical person that saw technology being leveraged in a stroke program to not only help our patients, but also help our providers, I was able to show the good results, not only from the patient side, but the satisfaction that the physicians and providers felt, which was key, because then those conversations kind of spread throughout the system, and then other physicians really saw opportunity for their service line to grow and to utilize this technology for them to grow and increase outcomes and satisfaction. So what happens with that is that there are a number of all of us that see new technology and say, wow, this is amazing, this is really great, but maybe our service line is not really ready for it. So my job and our clinical coordinator and our steering committee, and I can elaborate a little bit more on that, what our job is to take that interest from people and say, okay, how would this work? How is it going to first improve outcomes? How are we going to pay for it? And what's the value to the patient and the system? So, you know, those kind of conversations are ongoing all the time because we don't want to, it's just kind of like robotic surgery, you know? Just because the technology is out there and just because it's something that's slick doesn't mean that we should be using it for every type of procedure. So telehealth is kind of the same way. Just because it's new and it's something that can, you know, be leveraged, it's not adding value to the patient and the organization, then it's something that needs to be questioned. We do this in PNT, we do this in our Evidence and Value Committee when we're looking at new technology. So that it's very important that we evaluate all of those approaches and initiatives.
Great, thank you. Another question that is sort of aligns with a comment you made there was, this comes from Dr. Leavenworth. Do you have a steering committee or decision board that drives your telehealth program decisions?
Yes.
I know you mentioned it there, but perhaps you can elaborate.
Yes, we do. We have a steering committee that is made up of clinical, operational, and finance individuals. So we have our chief operating officer, our chief nursing officer, our chief medical officer, our CFO, myself, as well as our chief of vice president of supply chain and contracting, that make up that committee so that we have a conversation around what is it that we're going to do next with telehealth and how does that align with the overall goals, how does that align with the vision, how do we fulfill our mission to the community as well, because you know we want to make sure obviously that we're spending the dollars correctly, but again, it needs to add value to the patient, it needs to fulfill something in our mission, and then you know make sure that it's not going to cause a huge impact on our finances.
Great, great answer. And I think that a lot of programs out there are working with steering committees and are continuing to think about how they can use them to grow. A couple more questions here. Some are getting a little bit more on the operational side. So one from George asking, do you use telehealth consults for clinical education in real time, say to teach acute care and emergency response protocols as they are happening?
Not at this time. It's something that we are discussing, but we have not rolled out an educational component like it's being described in the question. You know, there are opportunities for collaboration that can be tied to an educational component. And I'll tell you how I see that. We have, like I said, in some of our remote partners, folks that are seeing some pathology during maybe a routine hysterectomy or something that they're concerned about. And we have a group of very talented GYN oncologists that work for our system that would be able to collaborate with those individuals in the OR without actually having to be there. I think there's an incredible opportunity there because maybe those GYN surgeons at those remote sites can move forward with this surgery with the support of these folks here, or is it something that's much more intricate that would then lead to them coming to see a subspecialty at our site? You know, as we get bigger and as we have more population to manage, and we have these type of partnerships, we want to make sure that our patients are either staying at their sites so that they can continue to get the care that they deserve and it's going to provide quality, or that they come to an appropriate higher level facility so that they can get that appropriate care. But using this type of technology is going to help us load balance, because the expertise will be at the very site in the front line to help decide, yes, they need to come to us and that's the appropriate transfer, or they should stay there and have this type of care because that's going to be the appropriate thing for them to do. And I can't tell you how many times when you talk to academic centers and even ourselves that we get transfers that were, you know, when you look at them, look at that patient again, like, you know, we could have probably not needed to send this individual. I think burn centers have done a really good job of managing those type of transfers because, you know, using asynchronous type of technology with pictures and sending it encrypted to their sites, that really helps them manage and minimizing the transfers that would be needed to be done. And that's just one example of I think, how it's been utilized well and how we need to use it.
Great answer, Dr. Caicedo. Appreciate that. Another question here from Samuel asks, how are the physicians in the post-acute space reimbursed? Is it a shared incentive or some other model?
Perfect. That's a really great question. So the folks in the post-acute care network are hired by the nursing home to provide those services. So right now they get a, I guess it would be a salary or for covering that nursing home, and then they would be, if they were getting a phone call about somebody who was decompensating, it's the equivalent of doing the phone call or beaming in. Because we're still within a metropolitan statistical area, they're not going to be able to bill that encounter for that patient unless they did a note and came in and actually saw them or whatever the case may be. So it's not something that they're getting able to bill or getting extra pay for those virtual encounters. However, the opportunity that is present for our post-acute care network partners is that if there is a shared savings that the physician is helping to achieve and the staff is helping to achieve by using Interact and SBAR and the telehealth technology, then there is an opportunity to incentivize those providers to say, hey, we were able to save $250,000 just here. I think a percentage of that needs to be part of some sort of incentive program to those physicians that work at those sites, if they're using that technology. It's not something that's being utilized right now that I know of, but I think there is an opportunity, and we have been having conversations with some of the administrative folks from those facilities just about that.
Great answer, and I think you know, a lot of people, as you continue those conversations, you know, would love to hear updates on where those go. So we'll track that and provide it, you know, as you continue to explore. One more question that I have is from Cynthia, and it says, from a care coordination perspective between PinnacleHealth and the skilled nursing facilities, what are the key clinical interactions that drive down the readmission rates?
So one of the things that we put in place, or we had discussions on, was let's look at the data. Let's look at what type of patients end up back in our EDs or readmitted to our hospitals from a specific nursing facility. Was it a medication issue? Was it a fall? Was it a decompensation of some chronic disease that they had. And why did it go to that? Were they, discharged too early? Were they not identified as decompensating in a timely manner so that something could be done early enough so that it decreased the potential for a readmission or a visit back to the ED? So we started with the data. We started looking at those things, and then we helped them identify what tools they needed in-house. EKG machines. Not all nursing homes have an EKG machine. Do they have pulse oximeters? Do they have the people with the right skill set to help identify when somebody is decompensating? That's where some of the Interact tools came. A way to document that so that we could say, okay, by the time we got to SBAR, we're calling the doctor, we have a very succinct plan and a set of data on that patient that leads to that situation, and a recommendation from the nurse to that physician to say, you know what, I think this is what's going on. Here's what Mrs. Smith has been doing for the past 4 hours. Can you please beam in and see the patient? So that created a very kind of standardized way for the staff to evaluate, really communicate, and then the physician to then beam in and evaluate those individuals. So I think according to answer the question, according to the nursing home, we identified different things and different gaps that they needed to have fulfilled in order to provide better services and identify patients early. Obviously, we started focusing and wanted to focus on those DRGs that were going to increase those readmission penalties. So those CHF, those AMIs, those COPD, any of the joint, post-joint folks were also folks that we focused on greatly.
Thank you, Dr. Caicedo, and thanks for a detailed response to a rather broad question, but I think that helps a lot of people understand some of the challenges that they might face, or where they want to, what they'll have to investigate as they try to roll out these types of programs. Sure. So I'm going to turn it back over to Larissa. That is the end of our question and answer session, and thank you again, Dr. Caicedo. We appreciate your time, and Larissa has some closing remarks for us.
Thank you, Andre. Yeah, just again, we would like to give a huge thank you to Dr. Caicedo and PinnacleHealth for today's presentation. For additional questions or information, please contact us at questions@intouchhealth.com, or you may contact Dr. Caicedo directly at the email address on the screen. And then also, please visit our website to find a recording of this webinar if you're interested in re-watching the webinar or sharing it with someone else. And you'll also get to see a list of upcoming webinars in our series, also on our website. Thank you again, and at this time I recommend that everybody log out of the GoToWebinar. Thank you.
Thanks, folks.